I think we should start now. And for the interest of the audience, I would like to repeat myself. This is ERA Protocol webinar series. This will have 3 volumes. First volume was covered last month, and the topic of the first volume was controlling, how important it is to control endogenous progesterone. Today is the second volume, and here we talk about the importance of the ERA cycle protocol and replication. And the speaker is none other than Dr. Tiffany Stankiewicz. I would like to just briefly, introduce Dr. Tiffany to all of you. Dr. Tiffany thanks, Tiffany. Thanks for being here with us this evening. And it's a morning for you, I can understand. Early morning. Just a very quick introduction. Dr. Tiffany Stankiewicz earned her bachelor's degree in animal biosciences from the Pennsylvania State University and PhD in genetics from University of Kent, where her thesis centered on optimizing IVF outcomes by controlling both embryonic aneuploidy and endometrial receptivity using genetic testing. Tiffany has over 15 years of clinical laboratory experience as a fully trained embryologist and is certified by the American Board of Bioanalysts as a technical supervisor in both embryology as well as andrology. In addition to clinical laboratory experience, she has coordinated many aneuploidy and single gene cases as PGT director at a large IVF clinic in Philadelphia. Tiffany made the move to reproductive genetics in 2016, where she became the PGTA lab manager at iGenomics New York. In 2017, her primary focus in the company shifted to endometrial testing when she took on the role of endometrial specialist, concentrating on ERA, EMMA, and ALICE. As you know, we have 3 broad tests for endometrium health. Today, she serves as the Global Endometrium Product Director for iGenomics. Tiffany has published and presented research at congresses such as Preimplantation Genetic Diagnosis, International Society, American Society of Reproductive Medicine, and the European Society for Human Reproduction and Embryology, that's ESHRE, and the Pacific Coast Reproductive Society. She is an instructor at Eastern Virginia Medical College and is a member of the American Association of Bioanalysts, the College of Reproductive Biologists, and the American Society of Reproductive Medicine. This was something about Tiffany. And Tiffany, once again, thanks a lot. And I would like to hand over the session to you. Thank you.
Perfect. Thank you, Vikram, for the introduction, and thanks for having me here today. So we're going to go ahead and get right into the webinar. As Vikram said, this is volume 2 that we'll be presenting today, and it's the importance of the ERA cycle protocol and replication. If you missed volume 1, that was from April 6th. You can find that on our YouTube channel, the iGenomics webinar webpage, or as Vikram said, you can just drop your email in the chat box and we can send you the link directly. Just to give you a little bit of an update, we will be holding volume 3 on June 21st. So look out for email communications and other communications regarding that, that webinar volume. So as mentioned, today we're going to again talk about the importance of ERA cycle protocol and replication. I do want to start with a brief introduction again, especially for those of you who did not yet attend or view our previous volume. So we know that implantation is a significant rate-limiting step, not only in human reproduction, but particularly in IVF. And implantation itself hinges largely on two essential players, the embryo and the endometrium. So it's true that for years we have focused on optimizing the embryo, and that's where a lot of our attention has gone to. And this includes new insemination techniques, so moving from standard insemination, or if we go further back, ZIFT or gift insemination, to intracytoplasmic sperm injection. We've improved our culture media systems. We've also improved our incubator systems, introducing technologies such as time-lapse. The way that we freeze embryos, moving from slow freezing to vitrification, improving survival rates for these frozen embryos. And probably more recently, the wider introduction of genetic testing, particularly for aneuploidy screening. But even when we apply these advanced technologies, such as aneuploidy screening, these implantation failure still occurs in about 1/3 of the cases. So that leads us to look to the other side of the equation, which is the endometrium. So the ERA test, or endometrial receptivity analysis, is a molecular assay used to determine each woman's unique personalized embryo transfer timing, therefore synchronizing the embryo transfer with the individualized window of implantation. Now, this is important because we had assumed that all women were going to be receptive at the standard timing, but now we know that just like many other aspects of an individual, there are unique considerations, one being when her window of implantation lies. At this time, ERA uses next-generation sequencing to measure the expression of 248 genes involved in human endometrial receptivity. After sequencing is performed, an in-house designed computational predictor analyzes the data obtained and classifies the endometrium as either being receptive or non-receptive. This result is then coupled with a recommendation for a personalized embryo transfer, or PET, according to each patient's specific endometrial profile. Now, there are many publications, both performed internally and externally, showing the efficacy of ERA, particularly in the indicated population of RAF. And here we demonstrated that synchronization between an implantation-ready embryo and a receptive endometrium increases the chances of success in ART. Other groups, as mentioned, have also published similar results from their own patients after guided embryo transfer according to the ERA results. You'll see here that I have a list of publications. These can be found on the iGenomics website. We just actually launched a new endometrial landing page with resources for clinics and patients. This also highlights tips from our scientific advisors around the world, resources such as a publication list, and clinical tools such as the PET calculator and ERA checklist. So tune in for that for additional resources. Now, I do want to take this time to highlight a more recent publication. So this was a systematic review and meta-analysis published in September 2023. Here, the authors assessed 36 different therapies for recurrent implantation failure. This analysis included 29,906 patients with RAF, and what they showed is that ERA is among one of the top therapy or interventions to improve implantation rate and live birth rate in the RAF population. Furthermore, the combination of ERA and PGTA is ranked as the #2 therapy to reduce miscarriage rates. This particular reference will also be found on the endometrial landing page and the publication list mentioned on the previous slide. So just to summarize our introduction before we move on to the actual content of the webinar, as it has been demonstrated, the synchronization between an implantation-ready embryo and a receptive endometrium with ERA increases the chances of success in assisted reproductive treatment. How can we replicate these same findings and optimize ERA clinical outcomes for all patients? And that is the objective of today's webinar. So the answer here is going to be ERA protocol compliance. Now, why is protocol compliance so important when it comes to ERA? And there's one main answer, and that is reproducibility. Reproducibility is absolutely necessary in order to ensure optimal outcomes for ERA. So what we expect or what we observe in the ERA mock cycle, we need the same expectation in the subsequent transfer cycle. So for example, if in the ERA mock cycle, we perform biopsy and HRT at 120 hours, and the patient is receptive at 120 hours, we also need to ensure during the personalized embryo transfer or PET cycle that she is also receptive at 120 hours. So again, we're synchronizing the implantation ready embryo with a receptive endometrium. So here I'll summarize on how we accomplish this reproducibility. Now, as far as reproducibility itself, I often get questions, well, how long are the ERA results reproducible for? So we've studied that the ERA results have been reproducible up to 40 months. In fact, in this particular publication, we found total concordance for all patients enrolled, where transcript variation between cycles, even 3 years later, are quite rare. So you can go back to the April 6th, volume 1, where I go into more detail about this particular publication. But again, it's reproducible as long as you're replicating the cycle protocol and patient conditions are replicated. And what I mean by this, we have similar uterine conditions and similar patient BMI. Now, this has been challenged as far as reproducibility of a transcriptomic profile from cycle to cycle within even the same patient. And again, you can refer back to the volume 1 webinar on April 6th, where we go into this publication to further detail. But our response actually showed in this particular letter that the ERA is quite reproducible from month to month. Again, ensuring that the same cycle protocol is replicated. This is key for reproducibility. Now, what can affect the reproducibility of ERA? Well, overall adherence to the recommended PE timing. If we find that receptivity exists at, say, 144 hours in that HRT cycle, then it's important that you're transferring in the personalized embryo transfer at 144 plus or minus 3 hours. If we were to transfer, say, at 130 hours, we may be transferring too early in that patient. So adhering to the recommendation is essential. Also, replicating the cycle type, HRT or natural, in both the mock and the personalized embryo transfer cycle. So in this case, we wouldn't want to perform the ERA mock cycle in an HRT and the transfer in a natural because the results may not be reflective in both of them. So even within the same cycle type, we need to also replicate all cycle medications. So this includes progesterone administration type, doses, etc., in both the mock and the personalized embryo transfer cycle. So in this scenario, what can affect reproducibility? If we were to use IM progesterone in the mock cycle, but vaginal progesterone in the transfer cycle, we may not have reproducibility of the initial results. And I'll actually go into this in more detail with real-life examples in the following slides. We need to also consider the use of additional medications outside of just estrogen and progesterone, so gonadotropins, steroids, etc., and their effects on reproducibility. Major shifts in patient BMI between the mock and personalized embryo transfer cycle should also be considered. So if your patient had a BMI of, say, 20 in the ERA cycle, and then in the personalized embryo transfer, maybe this occurred a year or two later, her BMI went up to 26, then we could have an effect on the reproducibility of results because the change in body fat content is going to change how the patient metabolizes hormones. Since the endometrium is hormonally regulated, this could affect the transcriptomic profile and also the patient's personalized window of implantation. alterations to the uterine cavity, so any surgeries. In this sense, we say that surgery should be completed before the ERA mock cycle occurs, not in between the mock cycle and transfer. We want the uterine cavity to be in a similar condition in both mock and transfer cycles. Endometrial thickness and pattern is also important. We should have a similar endometrial thickness and pattern between the two cycles. And as discussed in the previous volume, elevated endogenous progesterone levels can certainly affect the reproducibility of ERA. So we ensure ERA reproducibility by ensuring proper protocol compliance. This is key. So with that said, unfortunately, protocol deviation is quite common. We even see it in our own RCT that was published back in 2020, where we had a 50% dropout rate. This was 30% higher than anticipated. And a large contributor to this dropout rate was no protocol compliance. We even see it in external publications where they present data that is not reflective of the true ERA. But when we use the clean data, we see much higher implantation rate, cumulative pregnancy rate, and cumulative live birth rate when using ERA in a personalized embryo transfer. And probably these deviations had to do with, again, poor protocol compliance. If we're not ensuring reproducibility, we cannot ensure that we're transferring at the optimal time for the patient, and hence we could be affecting the patient's clinical outcome. So it is very important to make sure that we're following the protocol so we can give the best to our patients. This study, along with the previous slide, again, is discussed further in Volume 1 webinar. So today, I want to talk about basically these 3 points: replicating the cycle type, replicating the cycle medications, and considering the use of additional medications when carrying out the ERA test. So I want to refer first to the endometrial manual. This can be found on our website. You can request it from your iGenomics rep. But we go into detail on how to properly adhere to the protocol for ERA, EMMA, and ALICE. So I just take some of the content related to the topic today. And one of the first paragraphs to review is that ERA diagnosis is valid for the type of cycle in which the test is performed. And therefore, the embryo must be transferred in the same type of cycle and the personalized window of implantation within which a receptive diagnosis is obtained. Therefore, the type of cycle for biopsy should match the type of cycle planned for embryo transfer. And this goes back to the point. We don't want to perform ERA biopsy in a HRT cycle and transfer in a natural cycle. We want to replicate the cycle type between both the mock and PET. So to enable reproducibility results, the ERA test must be performed under identical conditions as the subsequent transfer cycle. So this does not only mean cycle type, but also treatment and method of administration of medications, dosage, etc., etc. And the ERA must always be performed during either a hormone replacement therapy, or HRT, or a natural cycle. ERA cannot be performed under controlled ovarian stimulated cycles. And the reason for this is that FSH, gonadotropin stimulating hormones, leads to supraphysiological hormone levels within the patients. This can lead to conditions that may not be reproducible from cycle to cycle. And for this reason, the ERA biopsy and transfer must be performed in either HRT or natural cycle only. Now, when carrying out an HRT cycle, what do you need to keep in mind? So HRT obviously involves treatment with both estrogen and progesterone to prepare the endometrium in a controlled manner. When you're performing the ERA in the HRT, usually the patient will start estradiol on the first or second day of her menstrual cycle. Ultrasound assessment is then performed about 7 to 10 days later. Now, this is important to note, we do not recommend more than 17 days of estradiol therapy prior to starting the progesterone intake. The reason for this is that extended estradiol protocols can lead to endometrial bleeding. We have associated endometrial bleeding with non-informative ERA results, which then we don't have conclusive answer for the patient. They then have to undergo a new mock cycle and biopsy. So no more than 17 days of estradiol priming before starting of progesterone. Now, we discussed this in the previous webinar. Once we actually reach an endometrium of ideal thickness, about 6 millimeters or more, we want to ensure that serum progesterone levels are less than 1 nanogram per mil within the 24 hours prior to the first intake of exogenous progesterone. When we actually start the exogenous progesterone, we consider this P plus 0, and then the biopsy is taken a full 5 days later or 120 hours later on P plus 5. You can see here in the figure to the right, this just summarizes what I had mentioned in the first paragraph. So we start our estradiol priming. Once we ensure endogenous progesterone levels are less than 1 nanogram per mil, exogenous progesterone can start within the next 24 hours, and biopsy is taken 5 days later after 120 hours of progesterone exposure. Now again, just to emphasize what we talked about in the first volume, it is important to ensure no ovulation and that endogenous levels are less than 1 nanogram per mil. The reason why this is important is because even small concentrations of endogenous progesterone can initiate the secretory transformation. So we want to ensure that our starting point is the first intake of progesterone. That way we can properly replicate the cycle from month to month. And then finally, the personalized embryo transfer timing will be based on the total exogenous progesterone exposure time. You will note that on the iGenomics test requisition form for ERA, we do ask for daily dose of exogenous progesterone and progesterone administration type. This helps us know what protocol the patient was under, particularly in cases where we have subsequent biopsies from the same patient. We want to understand if the cycle protocol has been replicated or not. So for example, if we see a change in dose or we see a change in administration type between different cycles for the same patient, we know not to correlate those results and instead to interpret them independently, because even a small change in dosage or a change in administration type can affect the window of implantation. Now, what about if you're performing a natural cycle? For natural cycles, we always need to have a reference date regarding ovulation timing. And this could be one of the following three. HCG trigger is the recommended protocol when using a natural cycle. And that's because you have the greatest amount of control and it allows for more accuracy in the PET because we're controlling when the patient's actually taking her trigger. So the HCG is administered according to the routine parameters in a natural cycle. Usually one of the leading follicle size is 17 millimeters or above. The day of HCG administration is considered HCG plus 0, and the biopsy will be taken 7 days later or 168 hours after HCG triggering. You can instead opt to use an LH surge. It is important to properly detect the LH peak using either urine or blood measurements, and where you see a negative, positive, negative pattern in 3 consecutive days. The day of the LH surge is considered LH plus 0, and the biopsy again is taken 7 days later on LH plus 7. And then the third option is using the ovulation date. And what we want to see here is that ovulation is determined by ultrasound, and on this day we will consider ovulation plus 0. The biopsy is then collected 6 days after on ovulation day plus 6. Here, again, a figure to represent the protocol given on the left. And as in with an HRT cycle, it's also important to control for endogenous progesterone, making sure that this level is less than 1 nanogram per mil on either HCG or LH plus 0. The results in this case is that the personalized embryo transfer will be based upon HCG, LH, or ovulation phase. Now, what about a modified natural cycle? So we consider a modified natural cycle any of the natural cycle options on the previous page, plus additional exogenous progesterone supplementation. Now, this is a very important point to make, especially considering the ERA protocol replication, is that even though we're performing a natural cycle, either off LH, surge, HCG trigger, or ovulation, if we're adding any exogenous progesterone, we have to make sure that protocol too is also replicated. So not only do we need to consider, are we using the same administration type of progesterone, the same dosage of progesterone, but also the duration between the LH surge, HCG, or ovulation and progesterone start needs to remain the same. So for example, if you start progesterone 24 hours after HCG trigger in the mock cycle, you're going to want to start progesterone 24 hours after HCG in the transfer cycle, again, using the same exact progesterone protocol. So what can happen if the ERA mock cycle protocol is not replicated in a PET cycle? So let's take this example here. Say in the ERA mock cycle, we give our patients 400 milligrams of vaginal progesterone twice daily. The biopsy is performed at 120 hours, and we find that she is pre-receptive one day, requiring an additional 24 hours of progesterone prior to transfer. So now she's ready for her PET cycle, but we add IM progesterone to the vaginal progesterone protocol. We go ahead and we transfer at 144 hours according to the previous PET recommendation. But the problem here is that with the addition of the IM progesterone to the vaginal progesterone protocol, she actually achieves receptivity 24 hours sooner at 120 hours. And what we're essentially doing here then is that we're transferring, let's put this here, at the wrong time. The embryo then is going to be transferred into a window that is probably already closed, leaving no chance to implantation. Because if she is receptive 120 hours, now we're transferring in the post-receptive phase after the window is closed. So just a small change of progesterone protocol can make a big difference for patients. Now I want to give a couple real life examples here. You may notice some of these charts. Sometimes if the patient has multiple ERA biopsies, we need to understand if we can correlate those results or not. So if you recall on one of the previous slides, I said if we see a change in protocol, then we know not to correlate the results, but instead to report them independent of one another. However, if we do see that the protocols have been replicated exactly, then we know the results can be correlated. And sometimes we see maybe some special cases such as a narrow window of implantation that requires further personalization. So having this information is imperative. I know that filling out these additional charts that we ask for multiple cycles is time consuming, but it really leads to the best outcomes for patients. So let me show you what can happen when we change the protocol. So this was a patient case in which we noted that administration type of exogenous progesterone was different between their first and second cycle. So in cycle 1, they used vaginal plus IM progesterone, whereas in cycle 2, they only used IM progesterone. Now, what were the results in this case? So we look at cycle 1. The biopsy was performed at 120 hours in an HRT. This patient was late receptive, recommending transfer at 108 hours of progesterone exposure, so 12 hours earlier from the time in which the biopsy was performed. So again, late receptive at 120, using vaginal progesterone and IM. Now in the subsequent ERA cycle, the patient underwent a second biopsy, again at 120 hours of progesterone exposure in HRT, but she only used IM progesterone. In this case, she was found to be receptive at 120 hours of progesterone exposure. So we can see here, just change in administration type can affect the patient's transcriptomic profile and hence window of implantation. Now let's look at another example. Now in this case, the patient took vaginal progesterone only for all 3 cycles. So administration type stayed the same. However, the daily dose of exogenous progesterone changed. So we could see that she took one capsule 1 time a day for 4 days, and then twice a day for 1 day, and then once a day the morning of biopsy. In the second cycle, she took 1 vaginal progesterone once a day for 5 days. And then in the third cycle, she took 1 vaginal progesterone twice a day for 3 days, and then once a day following that. So even though we use the same progesterone administration type and dose, the number of doses change per day in each of the cycles. So let's see what happened to the results here. So in cycle 1, the biopsy was performed at 111 hours, again in the HRT, and the patient was found to be post-receptive. The recommendation with a post-receptive result is to perform a confirmatory biopsy 24 hours sooner. The clinic went ahead and performed biopsy at 87 hours, and a late receptive result was obtained, indicating that receptivity was again 12 hours earlier at 75 hours of progesterone exposure. And then in the third biopsy, they wanted to confirm receptivity at 75 because this is quite an early time to transfer a blastocyst. We do see receptivity found at 75 hours and subsequent success with transfers at 75 hours, though it's not as common as, say, a displaced window further with progesterone exposure. So at this point, though, at 75 hours, the result was pre-receptive with recommendation to perform biopsy 2 days later. So again, back to about 111 hours of progesterone exposure. So at this point, we know that this did not make sense, and we asked for the additional cycle information, and we saw that each cycle, the protocol dosing was changed. And this, again, can show the effects from cycle to cycle for a patient just by adding or subtracting an additional dose per day. So just to emphasize the charts that we get and the importance, for certain subsequent ERA mock cycles to finalize diagnostics, our team may contact you to collect information about the patient's mock cycle. This is to understand if the protocols were replicated exactly in order to know if the results from the cycles can be correlated or not. Correlation of the results helps our diagnostic team to review both results and provide a more personalized recommendation. For example, in the case of a narrow window of implantation. Without confirming this information and considering correlation, we may be missing a special observation that requires more personalized recommendation for treatment beyond what is provided by our algorithm. So you can see here that is what happened in the previous case. We knew at that point that none of those cycles could be correlated, so they each had to be treated independent of one another. And on the final report, we put this comment here, which you may have seen. It says this ERA cycle medical protocol was different from a previous ERA medical protocol, and therefore the 2 results do not correlate. Each result should be assessed separately. And this is really important because, again, performing ERA biopsies with the intentions to correlate, but changing the actual cycle protocol, it ends up being a waste of time and expenses for patients. So replicating everything exactly is key. So again, what can happen if the ERA mock cycle protocol is not replicated in the PET cycle? So using the same example from before, where we used 400 milligrams of progesterone plus 1 ml of IM progesterone, we received receptivity at 120 hours. In the same patient, we used 400 milligrams of vaginal progesterone 2 times daily and obtained receptivity at 144 hours with this particular progesterone protocol. So, if we were to use this protocol in the mock cycle, the 400 milligrams twice a day, we would see receptivity is at 144 hours. But instead of using this protocol, we use the PET cycle protocol of 400 milligrams plus IM progesterone. This would mean the transfer is in a post-receptive endometrium. Now, if we switch this scenario and we instead use 400 milligrams of vaginal progesterone plus IM progesterone in the ERA mock cycle, we see receptivities at 120 hours. But in the PET cycle, we use the 400 milligram vaginal progesterone only twice a day protocol, in which receptivity we know is at 144 hours. Then we're transferring into a pre-receptive endometrium. So yes, the embryo may implant, it may stick around enough to synchronize with the receptive endometrium, but it's not optimal. We're going to have optimal clinical outcomes when we transfer during optimal receptivity. And that's the whole point of the ERA cycle, is to optimize patients' outcomes by getting them pregnant sooner rather than later and preventing the wastage of embryos. So when changes are made to the protocol, these questions or issues can arise. Am I actually transferring the embryo at the correct time and optimal time? This can lead to embryo wastage, because there might be some scenarios where these two protocols will lead to receptivity at the same time, but it's impossible to know this without performing an ERA biopsy for each cycle type. So again, it's best to replicate the protocol in both the mock cycle and transfer cycle, so we're not wondering and questioning ourselves with this. The other question that comes up, should I repeat the biopsy to confirm receptivity with an alternative protocol? Yes, you can, but again, this is additional time and money for the patient. So it's best just to choose which protocol you want to use for transfer, and then make sure you're replicating that in the mock cycle. What about additional medication that may be used? So we know that some medication may affect the reproducibility of ERA results. One of those being gonadotropin-stimulating hormones, such as FSH for ovarian stimulation. We know that this can lead to elevated endogenous progesterone levels, which can then advance the endometrium prematurely, for example. So for that reason, we do not recommend the use of ovarian stimulation hormones or the use of ERA in controlled ovarian stimulation cycles. But what about other medications? We get this question frequently, and unfortunately, it's not possible for us to know the effects of all medications on the reproducibility of the ERA results. We would have to test medication by medication. Now, we do have some hunches on some medications that may affect the reproducibility versus others that may not, so we can guide you there. But the most prudent recommendation is to use estrogen and progesterone only in HRT cycles, not to add in any additional medications that may cause artifactual results. With that said, though, we know that this is not always possible, and other medications may have benefits when not considering the ERA. So in that case, if any additional medications are being used in the transfer cycle, then they should also be used and replicated in the ERA cycle. This includes both the medication itself and its associated protocol, because this will help us ensure reproducibility and omit any potential artifactual results. So one common medication might be the use of a steroid. So maybe Medrol is a common steroid used here in the US for transfers. I tell physicians if they're planning on using Medrol in the transfer cycle, then they need to replicate that in the ERA mock cycle. We want to make sure that everything is exactly the same from cycle to cycle. In fact, that's the best way to explain the ERA test. I explain it as if you were performing a science experiment. We want to keep every single variable exactly the same. The only thing that should ever change is progesterone exposure timing, and that's going to be from your ERA recommendation report. Nothing else should change, because if we change an additional variable such as progesterone administration type or dosing, then we don't know which variable can be affecting the outcome. So everything's identical except for progesterone exposure time if indicated to change. It's also important to note any medication the patient is taking outside of her IVF treatment. So perhaps she's taking a medicine that you weren't necessarily aware of. My recommendation would be to confirm with the patient any medication she's taking, because it could affect the ERA results also. What if it's necessary to change medication protocol between the ERA mock cycle and the transfer cycle? In some cases, it may be necessary to make this change of progesterone protocol that was initially used in the ERA mock cycle. We see this in cases where a patient may have an allergic reaction or sensitivity to that particular progesterone. If so, then our recommendation is to repeat the ERA biopsy with the new progesterone protocol to account for any shift that may occur between the different progesterones. So let's say that your patient had a vaginal irritation or just uncomfortability with vaginal progesterone, and you wanted to switch to IM progesterone. You would need to repeat the ERA to, again, account for any changes between the two progesterone administration types. Secondly, although it's always advisable to replicate the entire protocol completely, we do often get questions about the estrogen protocol. Can this be altered and still ensure reproducibility between the ERA mock cycle and transfer cycle? So yes, you can adjust the estradiol protocol. Sometimes we'll see that maybe the lining is not building similarly between the ERA mock cycle and the transfer cycle, and maybe the patient needs an additional 2 days of estradiol priming before progesterone start. This is fine because it is, as I mentioned before, still very important to ensure similar endometrial linings and conditions from cycle to cycle, because this can affect reproducibility. So again, we recommend no more than 17 days of estradiol priming before progesterone start, but you can certainly change the doses of estradiol or the days of estradiol administration in order to get similar endometrial thickness from cycle to cycle. So I will go into that just really briefly while we're on this note anyway. So for example, if in the ERA mock cycle, endometrial lining was 8.1 millimeters right before start of exogenous progesterone, but in the PET cycle, the endometrial lining is only at 5.3 millimeters. Additional days of estrogen or adjustment to type or dosage can be made to build a similar lining. So just to note here that endometrial conditions, including thickness, should be comparable between the cycles in order to ensure reproducibility results. When it comes to endometrial thickness, we should be within one of the 3 categories for both patient cycles. So either less than 6 millimeters, between 6 to 12 millimeters, or greater than 12 millimeters. If endometrial thickness categories differ between patient cycles, then we recommend canceling that cycle and retrying in the subsequent cycle to get a similar lining. So just to give an example of this, I show here another chart that we asked the clinic to fill out, and we saw a difference between endometrial thickness categories from cycle 1 to cycle 2. In cycle 1, we had a 10.6 millimeter lining, so between 6 to 12 millimeters, whereas in cycle 2, we have a 12.7 millimeter lining, or greater than 12 millimeter category. Now in cycle 1, at 120 hours in the HRT, the patient obtained a post-receptive result with recommendation to perform rebiopsy 24 hours sooner at 96 hours. In cycle 2, at again 120 hours in HRT, the patient received an early receptive result, indicating the transfer 12 hours later at 132 hours. Now, this could be due to the difference in endometrial thickness. However, it's important for me to disclose here that endogenous progesterone was not properly controlled for in either cycle. So we're also unable to admit a potential endogenous progesterone artifact in this case. So here we highlight again why it's not only important to replicate uterine conditions, cycle protocol, but also control for endogenous progesterone. So the conclusions here is that to enable reproducibility of results, the ERI test must be performed under identical conditions as the subsequent embryo transfer cycle. Furthermore, the ERI test and subsequent PET cycle can only be carried out in an HRT or a natural or modified natural cycle, and never in controlled ovarian stimulation cycle. When performing an HRT cycle, progesterone administration type and dosage needs to be replicated exactly in both the ERI mock cycle and the PET cycle. Here we demonstrated with 2 examples where even minute changes to progesterone protocol has affected the patient's window of implantation. When performing a modified natural cycle, progesterone administration type, dosage, and starting duration from either LH surge or HCG trigger should be replicated in both the ERA mock cycle and personalized embryo transfer cycle. So again, if we start 24 hours after HCG trigger or LH surge, exogenous progesterone in the mock cycle, we're going to want to start 24 hours in the later in the personalized embryo transfer cycle. Sometimes we see here that clinics will, maybe if the result is pre-receptive one day, they might do a 48-hour gap between duration of LH surge, HCG trigger, and progesterone. This will not lead to reproducible results and needs to be the same durational gap. So in that case, 24 hours. Additional medication administered outside of estrogen and progesterone should also be replicated in both the ERA mock and PET cycle to prevent artifactual results. Additionally, it is important to review any medications taken by the patient outside of her IVF treatment. So that leads us to our Q&A session. I hope this was helpful, particularly reviewing the different real-life cases and how just even very small changes in progesterone protocol can affect the window of implantation in patients. So again, we'll open up for Q&A now. Vikram will go through your questions. If we don't have time to answer all questions, we will follow up with email with the answers. And we also hope, again, that you'll join us for our volume 3 of the series, which will be on June 21st. So Vikram, I will go ahead and invite you back and we can start the Q&A.
Thank you very much, Stephanie, for this wonderful presentation. And I'm sure this might have been very useful for the doctors who are there in the audience. And I thank the doctors also for their patience. And now I'm going to the questions which have been posted here. Yeah, this is a question which requires an answer. Indian data on vaginal microbiome. Do we have any Indian data on vaginal microbiome? Data on ovulation induction era cycle and duration. There are many questions in this question.
I need to write them down.
Yeah. Do we have any Indian data on vaginal microbiome? And data on,
Okay, so we'll answer the first question. So we don't have any vaginal microbiome data. So with Emma and Alice, we look specifically at endometrial microbiome. So we don't study the vaginal microbiome at this time. But we don't have anything published, but we certainly have internal data that we can look at from region to region. And I do think that we would see a difference based upon which region we're looking at, because we know that microbiomes are influenced by external factors such as diet is a big thing. So I'm sure we would see some differences, say in India versus maybe the US. I think the diet in India is much healthier and much more diverse. So maybe we would see a difference in the microbiome. We can certainly do that, but at this point, we don't have anything published.
Another question from the same doctor is, do we have any data on ovulation induction era cycles? Have we performed any, natural cycle, era? Do we have any data on that
We
in
do
the
have some
natural
data.
cycle?
Yeah, we do have some
Yeah.
data on natural cycles. In fact, the ERI test was validated using the natural cycle protocol. So that was our initial publication back in 2011. Now, a lot of our subsequent clinical trials have been in HRT just to standardize things a bit more and for more control over the patient cycle. But certainly we do have some natural cycle data. And there are some external groups too who've published their data that was used in natural ERA cycles.
Is it a published data, Tiffany?
There are some published data out there with the natural cycles. So we see, in our opinion, we don't see difference or in our view, we don't see difference in, say, receptivity rates between HRT or natural cycles. And the clinical outcome data that we've seen is comparable between both. We know that natural cycles are becoming more common nowadays with the support of the corpus luteum helping with ongoing pregnancy rates. So we have gotten a question quite frequently in the last year regarding ERA. So the ERA is completely validated in natural cycles. We do recommend the use again of HCG trigger over LH surge just because it's a bit more easier for the physician to control the cycle by giving an HCG trigger. It's also very helpful in cases where maybe you have a late receptive result with just a 12-hour shift. Having the HCG trigger will allow you to account for that 12-hour shift quite easily versus maybe an LH surge where we don't know the exact time of the surge, and I would say probably almost all cases.
Well, Tiffany, this is the third part of the question. Duration and validity of error. How long is the error result valid for?
So we have found that the ERA result is valid up to 40 months. That's what we've tested up to. Now, it doesn't mean that it's not valid beyond that. We've only looked up to 40 months. However, clinically, we recommend repeating after 36 months because this may account for any changes within the patient herself. As I mentioned, a change in patient BMI can affect the reproducibility of the results. And that's because a change in body fat content will affect how hormones are metabolized in the body. And since the endometrium is hormonally regulated, this can affect where the patient's window of implantation lies. We also need to ensure that when we are carrying out the ERA, which I hope I emphasize greatly here, that the cycle protocol is replicated from cycle to cycle. Now, if you do have a case where a patient has undergone the ERA and she comes back for her second transfer, if she has a surplus of frozen embryos, you can proceed if you're within that 36 months with just the personalized embryo transfer recommendation, assuming again her BMI has not changed drastically, and also that her endometrium is in similar conditions as far as thickness and no major surgeries or changes. But if you have a patient in which maybe they only have one embryo left, you can go ahead and repeat the ERA and ensure that there hasn't been any shift that occurred.
So I hope this answers the last part of the question. Does this validity hold good even after a miscarriage or hysteroscopy?
Yeah, so we haven't seen an effect of the window of implantation following miscarriages or even live birth, cesarean section. We are looking into gathering this data, but that is our recommendation, is to say, okay, if again there's been no change in uterine conditions. Now, let's say a patient had a miscarriage with a D&E and then experienced uh, damage to her endometrial lining and now maybe has Asherman syndrome, then we would recommend repeating because we have different endometrial conditions. There before, maybe she had a very nice lining, 9 millimeter, 10 millimeter after estradiol priming, and now her endometrial lining can only get up to about 5 millimeters. This could affect the results, so we would recommend rebiopsy in those cases. But for a majority of patients, it would not be necessary following miscarriage.
Thank you, Tiffany.
Mhm.
We have another question. In subsequent era base transfer cycle, should the same protocol be replicated 100%? I think yes, you have addressed this, but still.
Yeah, I
And
mean, oh, go
yeah,
ahead.
please reply to this, then I have another part of this question.
So the first part of the question, uh, ideally, we want to replicate everything 100%. That is going to be the best case scenario to omit any potential artifacts that can affect reproducibility. Um, and then the next step to that question, if we have to change estradiol priming, that could be okay. You can add additional days, maybe take away a day, maybe adjust the dosage a bit more to get the lining into similar conditions. But for absolutely, the progesterone protocol needs to be replicated 100%. There's no adjusting this. Any small adjustment to progesterone protocol can affect the reproducibility. So we do not recommend ever changing the progesterone protocol unless you want to repeat the ERA biopsy to validate for that particular protocol. So ideally, yes, replicate everything. If you need to change estradiol, you can, but progesterone should never be changed.
Well, further to this, the doctor is asking how to proceed if response is inconsistent cycle to cycle.
I'm guessing the endometrial lining response, is that?
Perhaps.
Okay, I'll answer that. If it's not the exact question, then please type in the question again more specifically. But if, let's say, the endometrium is not building in a similar manner, then our recommendation would be to cancel that cycle and then try again the next month if you're not able to rescue it by changing estradiol, the estradiol protocol in that first attempt. Now, when you're performing the ERA, it's important to ensure that the lining you get in the mock cycle is what you normally obtain in the patient cycle. So if you normally have a patient who builds linings between 6 to 12 millimeters, no problem. But in the ERA mock cycle, she has an atrophic endometrium, then you shouldn't proceed with the biopsy in that cycle because likely in the subsequent cycle, she will probably go revert back to normal endometrial conditions, and then we're left with results that may not be reproducible. So that's the first important consideration. But if she has her normal lining in the ERA mock cycle, and then for whatever reason she's not building appropriately in the transfer cycle, then just cancel that month and then try again in the following cycle. would be the best recommendation.
Thanks, Stephanie. Another question is, do we have any data on ERA after downregulation with GnRH agonist like Zoladex for severe adenomyosis patients?
So we don't think that a extended downregulation protocol will affect the reproducibility of the ERA results. So in the US, we sometimes will do a 3-month Lupron treatment for endometriosis prior to the transfer cycle. In these scenarios, just to be, again, most conservative or prudent recommendation is to perform any interventions before the ERA mock cycle, not in between the ERA and the transfer cycle. However, I know that a lot of these downregulation protocols are supposed to occur just before the transfer cycle, so this may not make it possible to do the ERA cycle after the intervention in this case. Now, again, we don't think that this will affect the reproducibility results if you perform in between the ERA mock cycle and the transfer cycle, though we have not studied this directly. And we do know that adenomyosis is associated with a higher chance of a displaced window of implantation, and this is a potential indicated population for ERA, particularly because also adenomyosis patients have a higher occurrence of recurrent implantation failure. So it has to be, in my opinion, weighed on a case-by-case scenario based upon maybe the severity and exactly what you're treating. But ideally, you do want similar endometrial conditions between the mock and the transfer cycles.
So in short, we can say that, ERA cannot be done in cycles, which are, sort of COS cycles, control ovarian stimulation cycles, right?
Correct. Yeah, they should never be performed in controlled ovarian stimulation cycles.
Now, the next part of this question, though it's already replied, but it's my duty to read out to you. Does regular ERA timing apply after downregulation and vice versa?
So are we referring to the same downregulation protocol?
Yes.
Okay. Yeah, if the downregulation is carried out in a interventional, treatment cycle before the ERA cycle, again, we don't think that this will affect the reproducibility of results. Ideally, we would want the ERA cycle and the subsequent transfer cycle to happen very close to each other without intervention. But we understand that there are other anomalies that need to be, or conditions that need to be treated too. But we don't think the downregulation outside of the ERA mock cycle will affect reproducibility.
Thanks, Stephanie. One more question is there. Will change in duration of administration of estrogen priming prior to start of progesterone also alter the outcome, even if the progesterone supplement was well replicated?
Yeah, we have a little bit more freedom when it comes to adjusting the estradiol, especially if we're trying to obtain similar endometrial conditions. So this is no problem to add maybe an extra day or two of estradiol. We don't want to exceed 17 days of estradiol priming before progesterone start, because again, as I mentioned, this has been associated with endometrial bleeding. And particularly in the ERA mock cycle, we've linked endometrial bleeding to non-informative profiles. So no more than 17 days of estradiol priming, but alterations to estradiol priming can be made without affecting the reproducibility of the results. So we want to ideally, again, keep administration type and dosage the same. It's okay. Maybe you need to increase the dosage here or there with estradiol. But for, again, progesterone protocol should not be altered at all. The only change that should occur regarding the progesterone protocol is duration to or exposure to progesterone if indicated to do so by the ERA report.
Thanks, Stephanie, again. Another question is, will administration of hydroxychloroquine in PET cycle alter the outcomes if it was not used in the biopsy cycle?
Yeah, we haven't been able to study the effects of every medication. Obviously, this would be a very long clinical trial, probably not even possible to perform. So our recommendation, which is again quite conservative, but it's to help ensure reproducibility, is to replicate any additional medication that you plan to use in the transfer cycle in the mock cycle. Now, we know that that's not always possible, especially for some medications that the patient might be extremely expensive for. But to truly omit a potential artifact to the results, we recommend the replication of even additional medication, outside of estrogen, progesterone.
Thanks, Stephanie. Now, another question asks whether estradiol type, its route and its dose should also be kept the same in ERA and transfer cycle?
Ideally, yes. We want to try to change very little between the cycles. But as I said, if maybe the patient had a sensitivity or allergy with the estradiol, you can change that as long as the endometrium is building in a similar way between the mock cycle and the transfer cycle. So we want to make sure within one of those same categories, either less than 6 millimeters, between 6 to 12 millimeters, or above 12 millimeters thickness in both the ERA mock and the ERA and the PET transfer cycle. So try not to change estradiol, but if needed, it should be fine.
Well, Tiffany, we have a question. If the patient takes steroids in the PT cycle, but not in the ERA cycle, do we proceed with ET or cancel due to uncertainty of effects?
Yeah, we would recommend replicating that in the transfer cycle if possible. We know that some steroids may have an effect on the reproducibility of results. My recommendation too is to always consult with our scientific advisor team and our endometrial specialists that work in our laboratories, because they have experience. It's one of the advantages with iGenomics. Since we are a global company, we've received well over 250,000 ERAs from around the world. So we are experienced with many different protocols and medications, and we might have information on that specific medication that the patient is taking and any potential effects. But again, our most conservative recommendation, it's more like a blanket recommendation, is just to replicate everything exactly in the mock and transfer cycles to omit any potential artifactual results.
Another question from the same doctor is, if ERA results are valid for 4 years, would a change in the ERA testing algorithms have a bearing on the report of receptivity if the HRT protocol, the BMI, and the endometrial thickness remain the same?
So I guess what they're referring here is that any refinements we make to our ERA test, can this affect the results?
No, we say that the results are valid for 4 years, right? So the question is, would a change in the ERA testing algorithms have a bearing? I mean to say, for example, the test is done in 2020 and today it's 2024. So maybe we have had some changes in our algorithm
Yeah,
during these 4 years. So would this change in the algorithm have any bearing on the receptivity of the test which was done 4 years back, provided if the HRT protocol, the BMI, and the endometrial thickness remains the same?
Yeah, and that's the reason why we say clinically we recommend repeating the ERA before that 40-month period. And that's to not only account for any changes within the patient that may have occurred, but also any refinements of the ERA test. So as we gathered more and more samples worldwide, we've improved our test over the years. So for example, in 2017, we changed from microarray analysis to next generation sequencing, adding additional genes. In 2016, we introduced the transition phase late receptive, which would require 12 hours less. But overall, the transcriptomic profile for the most case would be the same. It's just maybe the recommendation may be more refined. And I think the best example of that is, again, the 2016 introduction of the late receptive phase, where instead of saying, okay, perform a new biopsy 24 hours sooner, we said perform transfer 12 hours sooner. So you can see here, this changed the recommendation, saving the patient an additional biopsy and giving a direct recommendation for transfer. So these refinements are happening the more samples that we receive. So it's something that you can consider into the equation of whether you should repeat or not the ERA biopsy after 2 to 3 years.
Thank you, Tiffany. Another question is there any role of prebiotics in improving implantation rate?
I'm sorry, any, I missed
Role
the
of
first.
prebiotics in,
Prebiotics.
yeah, in improving implantation rate.
We haven't studied the role of prebiotics. So with our M1 test, we do recommend probiotics when we see a microbiome that either is pathogenic. So after antimicrobial therapy, we will recommend probiotics to replenish lactobacillus levels. Or in cases where we just have maybe little to no pathogens, but also little to no lactobacillus, we recommend probiotics of lactobacillus in order to, again, replenish that population. And what we found there is that when we have either no pathogens and no lactobacillus or a high level lactobacillus, we see significantly improved clinical outcomes. Now, prebiotics are a bit different. They're like the food that you lay down for the probiotics, for the lactobacillus to flourish. So unfortunately, we don't have a lot of experience with prebiotics since we look on optimizing the microbiome at the lactobacillus level. But I don't see harm in using the prebiotics just to have that foundation or environment for the lactobacillus to flourish further. But we don't have any data on that.
Tiffany, another question from the same doctor is, if we have day 4 embryos and ERA receptivity is, defined as P+5, when should we transfer?
That's a really great question. So if you have, our recommendation is going to be based upon blastocyst, so day 5 embryo, day 6 embryo, because that is the stage in which the embryo is going to implant. It's not going to implant to uterus at the morula stage or the day 3 cleavage stage, but only once it reaches the blastocyst, hatches out of the zona pellucida, then can that embryo implant. So how do we adjust for a morula transfer or day 4 transfer? we would just subtract 24 hours from the recommended time for blastocyst transfer. So if a patient is receptive at 120 hours, we'll say transfer the blastocyst at 120 hours. If we're transferring a morula, then we'll subtract 24 from 120 and we'll transfer at 96 hours of progesterone. Same thing holds true for a cleavage stage embryo transfer. In that case, we would just subtract 48 hours or 2 days from the recommended blastocyst transfer timing. Now, this is a really great question, and I'm glad it was brought up because we still, even if we have the intentions of transferring a non-blastocyst embryo, so a day 4 morula or a day 3 cleavage stage embryo, we always want to perform the ERA biopsy as if we were transferring a blastocyst. So 120 hours of progesterone exposure. Because if we were to perform the biopsy, say, 2 days earlier, which is when we would normally transfer a cleavage stage embryo, I can almost guarantee you'll always get a pre-receptive 2-day result saying perform biopsy 120 hours, because we're trying to identify the window of implantation, which is when the endometrium is receptive, which is typically when the blastocyst reaches the endometrium, which will be after 5 days of progesterone exposure. So we don't have to account for that earlier stage embryo transfer until we actually get the recommended PET for blastocysts. We keep everything the same as a protocol for biopsy, always biopsying 120 hours in HRT and 168 hours in a natural cycle. Then we'll subtract from there. So again, morula stage transfer, just subtract 24 hours from your recommended PET timing.
Thanks, Stephanie. Well, this is the last question. If a hysteroscopy is performed after the ERA cycle and no major cavity distorting surgery is performed, is it recommended to repeat the ERA?
No, so if a hysteroscopy is performed, sometimes we see that physicians will perform the hysteroscopy at the same time as the ERA biopsy, which is fine. The only thing we recommend is that you perform the ERA biopsy before the hysteroscopy. We don't want to perform anything, we don't want to perform the biopsy after the hysteroscopy has been performed. So if you are performing in the same cycle, on the same day, take your ERA biopsy first. That way we're not introducing anything to the uterus that can lead to maybe an invalid or non-informative result, and then you can perform the hysteroscopy. Now, with that said, if you are performing a endometrio, so ERA, EMA, and ALICE, you wouldn't necessarily want to perform the hysteroscopy then, especially if you're giving prophylactic antibiotics, because it can affect the microbiome. But for receptivity only, it can be performed in the same cycle.
Thanks, Stephanie. I'm sorry I missed one question from one of the doctors. While estradiol can be given up to 70 days maximum, as you said, is there a limit for minimum number of days of estradiol? If endometrial thickness is 7 mm at 8th or 9th day, can we start progesterone?
Yeah, that absolutely. So the standard protocol that was provided to us by Dr. Carlos Simon, he usually has his patients on estradiol priming for only about 7 to 10 days. So it is possible to start progesterone after only a week of estradiol priming. There's no minimum here as long as the endometrial lining is built appropriately. And again, we would also assume that endogenous progesterone levels would be within 1 nanogram per mil, so you can start. So really, with that, we just want to avoid the extended or elongated estradiol protocol. And actually, Vikram, I don't know if there's a second question to that, but I had another thought regarding the hysteroscopy that I don't want to forget before we move on. Now, if in the hysteroscopy there is a condition or anomaly that is discovered and then a subsequent surgery is performed, then we would recommend a new ERA. But if it's a hysteroscopy comes back clear, then there's no reason to repeat the ERA. Sorry, I just wanted to get that point in.
That's very important. Thank you very much.
Mm-hmm.
This is the last question now. I know you have a deadline. If the error is receptive at P plus 3.5 days, when should we transfer day 3 embryo?
So if we have receptivity on 3.5 days, let me just do the calculation here. So that would be 76 hours? No. 72 hours? 72. So 8 and 84 hours?
84 hours. Yes.
Okay.
Yeah.
So if we found receptivity at 84 hours, and that was our recommendation for a blastocyst transfer, then we would subtract 48 hours from there. And that would leave us with 36 hours of progesterone exposure for a day 3 cleavage embryo. Let me just check my math there. 84
you're right.
minus
You're right.
48, 36 hours. So you would perform day 3 cleavage embryo transfer at 36 hours.
Thank you very much, Tiffany. It was really a very nice session, and it was a very important one. Thank you very much for taking up all the questions and replying to all of them. Thanks to the audience here. I can understand that this is a working day today, and we have long days in India these days, but still you're here. You were here with us. Thank you very much. And please don't forget to tune in on 21st of June for the third and final volume of this ERA webinar series. I know many of your colleagues have faced a lot of issues today in logging into the webinar, but we'll try to simplify it in the upcoming third volume. Thank you very much. Thanks, Tiffany. Thank you, everybody.
Thank you.
Bye-bye.
Bye.